All right. Thanks a lot, Tyler. These talks are all sort of interrelated, so I'll try to eliminate the repetitiveness of the things that have already been talked about and try to stick just sort of to the outpatient theme and stay away from the technique and things like that as much as I can. These are just my disclosures. As Tyler was talking about earlier, why do you want to do outpatient? Certainly the most obvious reason is patient safety. Healthy people don't need to be in the hospital hanging around people with resistant staph infections and their diabetic ulcers, medication errors, in much more crowded facilities. We have the same staff day in and day out. They know the routine, the patient satisfaction, the economics, just the things that are tangible, the cost of the implants, the cost of the surgery center, the things that are intangible, your time, the time in the facility for things like turnover of the instrument, sterilization. All of these things are cheaper in the surgery center, which saves both the patient and the healthcare system and the insurance companies themselves. And as Tyler said, the thing that's most beneficial to us as physicians is the direct control of each case. I've tried to set up my schedule now where I do a week in the outpatient center and a week in the hospital. And some of this is driven by insurance and patient comorbidities, et cetera. But it's really nice on the weeks where I don't have to go in and round. I just show up at the hospital or at the surgery center, do the cases. The other days I'm in the office, and there's no traveling all over town to one or two hospitals to round and see patients who are in the hospital. We have a system where we've made an arrangement with a home health agency, and they check on the patients the night of surgery and the day after. We also get a lot of people who come in from out of town, and so we've made arrangements with a couple of hotels around Columbia, and then have the home health agencies and the therapists go straight to the hotels. It's coming. The patients are demanding it. They learn more and more about it, and they hear about it, and so they're coming in asking for it. Is it faster, cheaper, and better in the surgery centers? I think it's certainly cheaper. I don't know about faster. I certainly think it's safer. So better, safer kind of go hand in hand, I guess. These are just some studies that have shown the destination at discharge is a true predictor of outcome. Skilled nursing facilities and transfer to rehab facilities themselves are independent and significant risk factors for adverse outcomes. Now, some of this is not directly related to the total joint replacement. People who end up going to rehab facilities and skilled nursing facilities, sometimes it's for social reasons, sometimes it's for medical comorbidities, and they need to. But if you can avoid these, you can certainly limit the adverse outcomes. And again, a statistically significant outcome is shown that going home is the leading independent risk factor for decreased readmission rates and poor outcomes. In order to have successful outcomes in the outpatient setting, you need to know your own limitations. You don't need to be trying new techniques in the surgery center. You need to prepare for the worst case scenario. Blood transfusion, cardiac complications, and then you're going to have more minor things, urinary retention from the narcotic pain medicine, spinals, etc. We've arranged a relation. We have a pretty good relationship with the two hospitals in town, and so we have a protocol where if something drastic occurs, we have the ability to get blood. We also have a relationship with the cardiac hospital, so patients can be transferred there. I will say we've had one catastrophe, which had nothing to do with a total joint, but one of my partners was doing a clavicle fracture, and a young girl had some type of aberrant anatomy with a thyroid vessel, and we actually had one of the CV surgeons come over to the surgery center and help him finish the case. And so we've developed a good relationship with the hospitals in town, and you just need to prepare for the worst. The patient selection is obviously critical. ASA 1s and 2s, BMI guidelines, we typically say 35 for hips, 40 for knees. This isn't written in stone. Hemoglobin A1C, again, you'll see different values. We try to keep it 7.1. Somebody has 7.3 with a glucose of 120. We're not going to turn them away. We have a good relationship with our anesthesiologists, and we tend to have the same few anesthesiologists every time. And we've tinkered with the spinal and made adjustments to help these people kind of come out of their spinal quicker. It helps eliminate urinary retention and prolonged stays in the recovery room. And we try not to get our patients cleared, but we try to get them tuned up to be good outpatient candidates. So don't just send your patient to their primary care doctor to get a medical clearance. If they have medical issues, use the primary care physician to help these folks get tuned up to become a good candidate for an outpatient procedure. And we've sort of picked out a few of the internists and hospitalists in town, and we got these guys' cell phone numbers, and when we get a patient who's a little bit iffy, we'll send them to them and say, hey, see what you can do to get this patient possibly set up to be an outpatient candidate. And we did this kind of thinking, oh, Lord, we're going to step on people's toes. If Dr. Goldberg's this patient's primary care physician, and I send him to Dr. Malter to get cleared, is Dr. Goldberg going to be mad? Well, what we found out was most of these primary care guys don't like doing these medical clearances. They'd rather be seeing higher acuity patients, and this thing's almost a nuisance to them. So they were very comfortable and almost thankful that we were sort of leading some of their patients to someone who would clear them and they didn't have to get involved. The hardest part of this is getting these protocols and guidelines intact. I'm in a group where 5 of us do total joints. 4 of us are doing knees and 2 of us are doing hips, and trying to come up with protocols that everybody can agree on is next to impossible. I can't get my 3 kids to order a pizza without a fight on what they want on it. So getting 3 or 4 orthopedic surgeons who all know that their individual technique is the best and everybody else's is wrong, it's just difficult to get people to agree on what the guidelines and the protocols should be. And this is across the board, from the pre-op through the recovery room through discharge. What antibiotics to use, what pain cocktail to use, what anesthesia to use. To come up with a protocol is the hardest thing we had to do, and probably took the longest to get us started down this path of doing outpatient total joints. So this is sort of the catch-all slide that sets somebody up to be an outpatient. First, the patient selection, the anesthetic, the efficient surgical techniques and equipment, the multimodal pain management with periarticular injections, pre-op medications, etc. I won't get into the different recipes. I'm certainly glad to if you want to contact me, but we have guys who use Exparel, Marcaine, Toradol. We have guys who use ketamine, Marcaine, and so there's all kinds of cocktails that we use, and so I'm not going to go over all of them because each person has sort of their own. We've sort of moved away from Exparel for cost reasons, and it's effective, but it doesn't seem to be grandly more effective than Neuropin with ketamine or morphine and other cocktails that are much cheaper and seem to be almost as effective. We try to limit the narcotic use. In my total hips, I give very little narcotics to the patients who are not taking narcotic pain medicines pre-op. The knees are a little tougher to do that, but the rush or the eagerness to do outpatient total knees is the first or second slide Tyler showed you. The expansion of the number of total needs is logarithmic. And so that's why insurance companies and Medicare all want the outpatient total needs to come along as fast as it can. So post-operatively, our biggest hurdle was getting these folks to void. In our first 50, we actually had one guy come back to the ER that night because he had urinary retention, and even though he was voiding, he would drink a bottle of Gatorade and void 100 cc's, drink a bottle of Gatorade. And so, you know, it's practicing medicine, and so now we ultrasound these people prior to discharge to make sure they're truly empty in their bladders. And, you know, that's not a horrible complication, but it is something they return to the ER for, and you get dinged. And obviously, we don't want people returning to the ER if we can help it. Advancing their diet, physical therapy. Again, we have parameters. They're not magical, but it's 150 feet. You've got to be able to do stairs and get out of a chair with just a little bit of help. And again, we try to limit the use of narcotic medicines as much as we can. Discharge, again, as I said, ambulation, oral intake, oral pain control, bladder scan, and we have arranged to have home health nursing visits and home PT visits the following day. We have nursing visits the night of and the morning after surgery. Patients go home. A lot of this is coaching and education pre-op, the home health nursing and therapy, and we have staff that calls them the next day, and we really try to coach these people ahead of time if they have a problem, whatever it is. The dressing's got blood on it, I'm nauseated, don't go to the ER, call us first. And we have somebody on call, and actually each physician is on call for their total joint patients the first night. So the on-call doctor doesn't get called if a total joint patient's having a problem. The actual surgeon gets called. So how can Medacta and the efficiency need help? Well, obviously, it's a much, much smaller tray, as you've seen. I won't get into this rehashing everything they've gone over, but it's one tray that's disposable. You have a few general instruments that you'll use on every knee. If I have my knee done, I would like to have something that's not been in Tyler's knee. So it's, from an infection risk standpoint, I think it's obviously single-use, sterilized, lightweight. We didn't even know our sterile processing wasn't up to code for total joint trays. We were doing sports things, and so we had to get new sterilizers to do these larger trays when we started doing total joints. So to start this, again, it's not the place to learn. Medacta has fabulous education seminars. It's a 1.5-day seminar. You have didactics Friday, cadaver lab Saturday. You can use the MyKnee, the standard efficiency GMK instruments, and it's just a good place to sort of learn the technique and then apply it to the outpatient setting. Here's this slide showing the full line of the disposable trays. As Tyler noted, this is a much smaller number of instruments, and it just really lightens the load in the surgery center for trays, for sterilization and cleanup. This is just the custom cutting guide for the MyKnee. This is what I use both in the hospital and the outpatient setting. Again, just a single-use tray showing a paltry number of instruments needed. So the benefits are for the patient and the surgeon. As Tyler showed, excellent clinical and radiographic results. The patients like the fact that this is the newest technique with the custom cutting guides. You get good, accurate knees. It streamlines the procedure, and it's a single-use instrument, so decreased in risk of infection. Again, the economic value is across all aspects of the surgery, in the operating room, sterile processing, all aspects of the surgery. You save money for both the healthcare system and the patient. That's it.